And welcome everyone to the PSCC Partners May workshop. We're very excited to have Erin Westphal from the SCAN Foundation join us to talk about making the business case for person-centered care. Very excited to have her on this month. But before we get started, I have a few housekeeping things that I wanted to go through, some upcoming events, and then I'll introduce Erin. But first, Libby Hoy is on, and she wanted to say hello to everyone. So, Libby.
Thank you, Lindsay. Hi, everyone, and thank you very much for joining our workshop today. I share in Lindsay's enthusiasm and excitement for Erin's presentation today around making the business case for person-centered care. I think this follows on from our previous workshop with Michelle Johnston-Fleece from the National Academy of Medicine, sharing the guiding framework. The business case supports sort of those components on the left in terms of getting full leadership buy-in, and so I really like how this is flowing together. So with that, and with my gratitude to Erin for joining us today and presenting this important work, I'll turn it back to Lindsay.
Great. Thank you so much, Libby. And as we are on today's workshop, I know a lot of you have been on before. We are still Zooming. So if you have some background noise, please mute yourself. You can feel free to share your video like I am, or not. It's okay, but love to see your smiling faces. And then throughout Erin's presentation, we will have some opportunity for questions and discussions, but if you have something at the top of your mind that you would like to share or ask, you can do so in the chat box, and you will see that if you hover over the bottom of your screen, and you can click the chat. I've already put a chat in there so those who are new can find it. And moving right along, just a little background for those who are new to PFCC Partners, or for a reminder for those who aren't. This is our mission. It's really to partner with healthcare organizations and the public to provide that collaborative learning community, which is exactly what we're hoping to do with these workshops. And as Lemmy mentioned before, really building upon each other. And sharing those proven methods, successes, and challenges to help guide the development of sustainable patient-family engagement structures across the entire healthcare continuum. In support of that mission, we have a few upcoming events. We are presenting a Skills Development Day on June 2nd in Northern California. And I'm sorry, we have a little bit of background noise, if you wouldn't mind muting while you're discussing. Or I'll mute you, sorry. I'm sorry about that. The Skills Development Day will be presenting on June 2nd in actually Sacramento, California. We will be presenting the Patient Family Advisor Skills Exchange, as well as the facilitator training at the same time. So for more information on that, you can go to our website. It's pfccpartners.com under our programs tab. We also, for any patient family advisors on the call today, we have the PFAN Network virtual meeting. That is the first Wednesday of every month, and the next one is on June 12th at noon Pacific Standard Time, and we're actually very excited to welcome a fellow advisor, Jamie Hicks. She will be talking about a recent conference that she has attended. And then finally, next month on our June workshop, we're excited to have Joan Gallegos from Health Insight talk about their journey from PFAC to boardroom. And with those updates, did anybody have any questions before I welcomed Erin? Okay, great. Then I will pass it right along. I'd like to welcome Erin Westphal, Program Officer at the SCAN Foundation, who will be talking about how to make the business case for person-centered care. Erin?
Great. Good afternoon, everyone. And it's great to meet all of you virtually. And I hope that the information that I have today, you'll find it helpful. As a program officer at the SCAN Foundation, I do work in a variety of areas, but really looking at that intersection of healthcare and home and community-based services. And how can we do a better job of integrating that care so that care is really focused on the individual and their goals. Before I get started today, I wanted to take a minute on the next slide to talk about the work of the SCAN Foundation. The SCAN Foundation we say we're in our teenage years now. We're about 9 years old, and we focus solely in the field of aging, specifically long-term care. And we think about our work in 3 thematic areas. The first is really focused on those that are dually eligible, and how do we do a better job of integrating the care and financing for those individuals. The second, and really the crux of my talking with you today, is around building the business case for person-centered models of care, and thinking about Medicare beneficiaries that not only have chronic conditions, but also functional limitations, because we know that that's what really drives utilization. And finally, creating a realistic set of policy solutions for long-term care financing. We do our work mainly in California, but also work at a national level. So there have been some environmental factors that have really contributed to the need to think about care for a vulnerable population. And before I really jump into some resources and tools we have for the business case, I wanted to take a look at what's been going on in the healthcare environment over the last few years. We're going to talk a little bit about increased lifespan, the impact of functional limitations, and then really things that drive cost for individuals. So I really love this next slide because it does a couple of things. It shows us what cause of death has been over the last 100 or so years, but also looking at life expectancy. So we all know that Medicare was established in 1965. And when you think about the average age of somebody in 1965, it was 69 years. So when Medicare was established, they anticipated that folks would be utilizing the program for about 4 years. But as we know, life expectancy has expanded greatly. And the reality is that as the environment has changed and people are living longer with chronic conditions, the structure and the reimbursement models for Medicare haven't kept up with that change. And I would say oftentimes don't support a vision of person-centered care, because reimbursement is really focused on the delivery of specific services as opposed to being outcome focused. And what we know on the next slide is that in 2010, almost a third of Americans had multiple chronic health conditions, about 97 million people. And almost half of them also had functional limitations. And so why is this important? When you look at this next graph, you'll see that the per capita Medicare spending for individuals with chronic conditions and functional limitations really increases. And increases dramatically. So if you have somebody who has 4 chronic conditions without functional limitation, you can see their annual spending is about $7,100 a year. When you have functional limitation added to that, you can see that it more than doubles in terms of the cost to the Medicare program. And just because we're spending more on these individuals doesn't mean that they're actually having a better experience, doesn't mean that they're living longer. It's really a question about what's the quality of life. And on the next slide, you can see that most Medicare beneficiaries who have chronic conditions and functional limitations, people always think, well, you know, those are the dual eligibles. But in fact, more than half of the individuals who suffer from chronic conditions and functional limitations are just Medicare beneficiaries. And this means that we need to look at the problem now. This isn't a future problem. And we need to look at not only income as being a driver of utilization, but also look at where people are, what's happening with their conditions, and the supports that they have in the community. On the next slide, we think about that a perfect storm has really happened. The beneficiaries that are the most vulnerable, those are with the most chronic conditions and functional limitations, that top 5% account for a tremendous amount of the spending every year to the Medicare program. So when we think about person-centered care, one of the questions is, why person-centered care? And you can see here on the slide that Hippocrates' Oath is really about doing the right thing for people. If we can change to the next slide, please. Doing the right thing for people based on who that person is, not necessarily what their disease is. And the SCAN Foundation is interested in supporting the scaling of person-centered models because we believe that if you increase the quality of the care and you increase a person's quality of life, that you will see reductions in costs to the delivery system. And so you have to think about, well, how, on the next slide, how do we get there? When the SCAN Foundation started our work, we thought, person-centered care, patient-centered, patient and family-centered care, all of these words mean different things to different people and how they use them in the delivery system. So we started by doing some work with the American Geriatric Society and some researchers out of USC to look at the literature to understand how is person-centered care currently being defined? What does it mean for not only people receiving care, but those providing it? And then bring together experts nationally to develop some consensus on a definition of person-centered care. And on the next slide, you'll see that person-centered care means that a person's values and preferences guide all aspects of the healthcare and support realistic health and life goals. SCAN Foundation was really specific to not define that one model or two models are person-centered, but rather identify with the help of AGS the core elements of a person-centered model and help the delivery system see that when you focus on a person's goals and you do these 8 things, and they're things that we all know about. They're care planning, their education, having a single point of contact. They're really simple things, but they're really hard to do and do in a well and coordinated way. But if you can do these things, that you are going to have better outcomes for the individual. So the number one reason for, again, engaging in person-centered care is to improve the quality of life. This picture on the next slide is really sweet, and everybody wants to. And we actually just had some polling results come out today through the Associated Press that most people think that they're going to go along in life and they one day are just going to drop dead, and that's it. But in fact, what we know is that people on average are going to live for 5 to 7 years, needing help, having limitations that affect their ability to have the quality of life that they hope for. So person-centered care, in our mind, is really on that focus about how do we improve quality of life. But we know from the second reason why person-centered care is important is about supporting a person to reduce costs. And if you can't make the financial argument about how person-centered care impacts costs, then these programs aren't going to be sustainable. So before I jump into really talking about the business case, I don't know, Lindsay, if we want to pause now to see if there are any questions about this first part, or if I should just keep going.
Sure, we can pause for any questions. There weren't any in the chat box. I'll double check. Nope. Did anyone want to speak up or have a question? No?
Okay.
Okay, we can move
Well,
right
hearing
along.
none, Then let's jump into the business case. So on the next slide, we defined the business case here for you, that in order for an organization to invest, there must be an economic benefit to a program. And we all know that money is really tight in all of the different aspects of the delivery system, and you can't necessarily just take dollars away for something because it's the right thing, because we know we want to deliver care in another way. You have to make that case for why. And with the business case, the question it must address is there an adequate return on investment? And so on this next slide, I'll take just a minute to talk about what the return on investment is. It's essentially, and we'll see an example of this in a minute, is the amount of dollars that you're putting into something, is the return, so the savings or potentially the reduced utilization, does that outweigh the cost? And this is really complicated. You could think about examples, in your everyday life. I drive a Prius, and I just got a new Prius after having my old one for a number of years. And the cost of buying a new car, the great thing is that my Prius now gets 60 miles to a gallon of gas, where my old Prius, I was getting about 45. So I'm going to see my return on investment really quickly in that case, because it's saving dollars for gas. Before I bought my Prius, my car averaged about 20 miles to gallon. So just return on investment are things we think about every day in life. And on the next slide, you'll see when we think about cost drivers, the return on investment is impacted by these different drivers. What we know is that in order for the healthcare sector to act, that there has to be some sort of risk-sharing structure. And this risk-sharing structure has to allow for flexibility in the delivery of care and the financing. And so right now, we know in healthcare that there are all sorts of opportunities, from accountable care organizations, bundled payments, value-based purchasing, and how organizations approach delivering care under these risk arrangements is important. So on the next slide, we think about that top 5% of Medicare beneficiaries, and we think about the potential negative financial impact that they would have on hospitals. I'm going to use hospitals, and I'm going to use hospital readmissions as my example moving forward here. So I think that this next slide is kind of fun, because what we think about is, for hospitals, they are now held responsible for readmissions for the same condition within 30 days. And this had to change how hospitals really think about how they provide care for a Medicare beneficiary. Typically, a readmission is about $18,000, and hospitals are going to be penalized for readmissions, meaning they had to cover the cost of that readmission. They couldn't bill for it. So they had to think about, okay, when we send somebody home from the hospital, what do we need to do in order to make sure that this person has what they need in the community? And this is a huge shift to how hospitals think about delivering care. Rarely did hospitals think about what happened outside of their four walls. There were some demonstration projects. Specifically, there was a CMS-supported project, the Community-Based Care Transitions Program, where for the first time, Medicare was providing funding to community-based organizations to provide transition services. And most of those projects were found to be highly successful in reducing readmissions to hospitals, therefore creating savings, but also avoiding costs. And that part about avoiding costs is kind of challenging, and it's hard to capture, but it's an important aspect. And we know that some specific models work. One of the things that the SCAN Foundation has done is some analysis of existing models. And you'll see on this slide that we have 4 models highlighted. The first is Grace Team Care. The second is the Advanced Illness Management Program, or AIM. Life Course is another model, as is Tandem 365. And what you can see here is that given the cost for providing these programs, what the return on investment is. So an example for Grace is that this is a model where we have a nurse practitioner and a social worker who work with a multidisciplinary team. Once an individual has been identified, an in-home assessment is conducted and a care plan is developed. The nurse practitioner and the social worker team report back the information to the interdisciplinary team, who then works with the primary care physician to implement this model. On average, the cost per individual is $358, but what we have found is that there's a 95% return on investment for this program. And the thing that's important to remember too is that when you implement a model of care for somebody, depending upon how long they're engaged with that care, the intensity will change as well. Grace has found that the first 2 to 3 months that somebody's a part of their program, that there's a high touch factor. There's a lot going on. But once that individual has stabilized, once the individual knows that the Grace team is there to support them, their needs taper off. But that doesn't mean that at some point there might be an event where the Grace team needs to come in and have a higher touch. So when we think about models, we have to think about the timeline that they're implemented for, and also how their costs could fluctuate over time. So on the next slide, specific to person-centered care, we think that there are 6 drivers for lowering costs. So the first is about utilization. The second is about those expensive medical events, whether they're emergency department use or something else. The effective models of person-centered care are really critical. And we make we have a strong bias that an effective model includes coordination with the community-based services, that there has to be some way to capture the savings. So in an environment where there is no risk, so you have an individual who has Medicare, they're not participating in a Medicare Advantage plan, so we call that original Medicare, and they just go to see their doctor. They're deductible, they pay 20% of the office copayment. When that person avoids a costly event, who benefits from that? Who captures those savings? It's a really important question. In some ways, we think about how person-centered care can increase revenue, and person-centered models of care aren't really costly. So with all of this in mind, it's very complicated. Models are all very different. The individuals who are identified to participate in these models, it's really critical. You can't just say, well, you can say the top 10% of our highest utilizers of medical services should be included. If you can narrow that down a little bit and get more specific, it allows you to be able to track an intervention better, to see what the costs are. There's lots of layers to this. And we thought one of the things that would be helpful based on our work is to develop a return on investment calculator. We know that many in the delivery system who are implementing models are a physician champion. And that physician champion has probably done some, what we'll say, back of the envelope calculations on cost savings. But we know in order for these models to really be adopted and scaled at a widespread level, that there has to be some convincing done at the C-suite, oftentimes with the CFO, to show that the cost is there. So on the next slide, you'll see what, and I apologize for the size of the fonts on this. The ROI calculator is available on our website. It's an Excel-based document, and I just tried to take some screen grabs so that you guys could get a sense of it. What this shows you right now are all of the things that we put into the ROI calculator to understand what our return on investment is. So It's about defining the population, looking at benefits and costs, looking what the net gain is to those to get to that return on investment. The tool was developed by Victor Tabush, who is the emeritus professor from UCLA and the past dean of the business school. I think one of the things that's really exciting about this ROI tool is that there is another foundation that has done some investment to look at how to make the tool be focused for a broader population, not just older adults, and really take into account social determinants of health. So you'll see that information, or that information will be available in the coming year. So the benefits of the tool that we think about, when we think about benefits, we've talked about reduced utilization, we've talked about cost avoidance, but there are some other benefits that are important for us to consider. This includes provider satisfaction. We know from all sorts of research about the healthcare sector that many doctors experience burnout and leave, and having to hire and train physicians is a costly endeavor. What we also know is in the delivery system, where there are models that help reduce provider burden, allow them to really get to the art rather than the process of providing care, that there's lower turnover. And when we think about revenue enhancements as these other benefits, we're thinking about star ratings, we're thinking about more people enrolling in a potential program because it does have higher quality, and this is important. And again, I just can't say enough how critical it is to focus on the targeting. How do you know which individuals would benefit the most from which intervention? So when you go to the ROI tool, it looks really challenging and really complex, but I promise you that it is easy to use. There are a couple of sets of directions. There are some embedded in the tool, but there is also something that you can print out. In the next couple of slides, we're just going to go over some of the components. So on the next slide, you'll see that this is where we're looking at the population. And here's where you put in your information about how many potential eligible members there are. And you can also take those members and put them in two different groups. And you can see here from the most severe, so we use 10% as the example, to those that are the next tier down, which might be that top 20%. And again, what this does is it helps you focus on who's going to receive this model and how are we anticipating their utilization. I want to point out two things that aren't captured on any of these screen grabs, but you can see there are these little tiny squares that say guide. And when you click on those, little pop-up bubbles come open, which help define what should go into these categories. So once you put in your eligible information for participation, on the next slide, you'll see that here's where we're capturing information on utilization. So what's the current utilization for this population? How do we think that the utilization is going to change? And what is that going to mean over time? Again, the tool allows you to do a couple of different things. On the left-hand side, you'll see where that yellow box is. You can check boxes to leave information in or uncheck them to leave them out. This is important when you get to the analysis portion because it allows you some flexibility. To the right of that, where you see it says change in utilization, there are these slider pieces that allow people to look at, okay, well, if I just move it over just a little bit, how is that going to change utilization and my ultimate return on investment? The next slide gives you a screen grab of what is called a scenario comparison. And when you put the information in the tool, what this allows you to do is to create a couple of different scenarios. And you create those scenarios in the tab, much like the one we just looked at, that asks for all sorts of information. And then you run the simulation, and you can see how if you do the first scenario, and you can see in this example, we had 400 individuals. And then the second scenario, 200 individuals, It gives you a sense of what that return on investment looks like for cost as well as savings. So it's a pretty dynamic tool. It also creates for you a set of charts and graphs based on the information you put in. I didn't include any of those in the slides today, but we intentionally had those created. So again, when a physician champion or another champion for the program goes to make the case for expansion or even implementation of the model, they have visuals that will be really helpful for individuals. So oftentimes we hear, well, this is all really great, but gosh, I mean, there's so much out there. How do I know what I should use? Where can I find more information about what's happening in the field? What kind of models exist? And I'm excited to share with you guys that just at the beginning of this year, ourselves and 4 other national funders, the Commonwealth Fund, the Robert Wood Johnson Foundation, Peterson Healthcare, and the John A. Hartford Foundation, launched the playbook for better care for people with complex needs. And on this next slide, you'll see a screen grab of the homepage of the playbook. And what the playbook does is it really curates and synthesizes resources that are available. The target audience for the playbook are providers, payers, and policymakers. And you can look at the information, as you can see, in a couple of different ways. You can sort the information based on key questions. So why invest in redesigning care, or who are people with complex needs? You can sort the information based upon who you are. So if you're a provider, the resources that are important or interesting to you may be different than those of a policymaker. Or if you're looking for care for a specific population, you can choose, I want better care for, and the resources are sorted based on the target population. The playbook has a number of resources on it. New resources are added every month. And again, these are curated so that individuals can get really a snapshot of what information is included, what the key questions are, and then there's a link to the full resource if you want to read some more. We are going through a second version of the playbook, and one of the things I think is going to be really exciting in the next version is to see where people are implementing innovation on a national level. So we'll have case studies so you can go and say, oh, this organization has this model and they're in a rural community just like I am, and how's that working for them? And read about both their challenges and their successes. So on the next slide, I have some additional resources listed for everyone. The first is just an issue brief, and it's really talking about the business case for person-centered care. The second bullet is a really large paper. It's about 50 pages long, but we know that most people won't read a 50-page document. So that's why we created the brief, which is about 8 pages long. And it really lays out the theoretical argument for the business case for person-centered care. When you go to the SCAN Foundation's website, at the second bullet, as you scroll further down, you'll find the return on investment calculator. You will also find, which is blank, there's also one that has an example scenario in it so that you can see and they're all just made up numbers. They're not based on anything. And as I said, there are the instructions for the calculator as well. So I think that I talked much faster than I planned to, but this is all of our information about where you can find us. My contact information is on the SCAN Foundation website, my actual phone number and email address, and we're here to help. So if you're interested in kind of putting in data on your tool, but in the ROI tool, but you're struggling, or if you have some specific questions, you can feel free to reach out to me at any time, and we will do our very best to help you navigate the use of the tool or answer any other information. So we have lots of time for questions, and Lindsay, I'll turn it back over to you.
Yes, thank you so much, Erin. That was really interesting and really good to see that there's something like this out there, especially that ROI calculator. Very, very cool. Are there any questions from participants for Erin? You can chat in or speak up.
Hi, this is Joan Maxwell, and I'm a patient family advisor in Walnut Creek, California, for John Muir Hospital.
Hi, Joan.
And thank you for your presentation. I was just wondering if you could give us a couple of examples of, how this is used, kind of from your experience. I just would be interested to hear, I appreciated what you said about the complexity of it and how difficult it is, but I'm wondering kind of in what circumstances you've seen it used and how.
Sure. So that's a really great question. And it's also really tough. When we, to provide some, I do have an example for you, but this is my disclaimer. When we put the tool up on our website, we didn't create it so that people would have to register to access it. So we have a hard time tracking who's using the tool because we didn't force them to give us their information. We do hear from folks, but so there's just that disclaimer. We know that it's downloaded hundreds of times a month, but again, we're not always sure on who's using it. But I'll give you an example of how this is important. So several slides back, I showed about the 4 programs and their models and their return on investment. One of the programs, the AIM program, the Advanced Illness Management Program, that is a program that was developed by Sutter, and Sutter had implemented this program in one of their regions in Northern California. And it's a great program. There's a multidisciplinary team. I would say that it's a very medical model. The only thing that it's missing from being person-centered is that active connection and collaboration with community-based resources. But they have individuals participating in this program who are really frail. They talked about these individuals being folks who, were really in the last year of their life. And some of them probably were hospice eligible, but not ready to have that discussion yet or to accept hospice as a provider. Very frail, very high utilizing population. And what was really great is that the individuals didn't know that there was a whole team behind them. They knew they just needed to call Sue, and that Sue would make sure that they got to her doctor's appointments, to make changes. If there was a change in condition, that Sue could make it happen, make everything, all the needs come true for the individual and their family. So there was a physician champion for this program who knew that they were doing the right thing. He'd done some initial analysis on, like, well, gosh, if we're just saving at least one emergency room visit or one hospitalization for this population, wouldn't that be great? But the analysis wasn't structured in a way that allowed this physician to go to the C-suite and make the case for expansion of the AIM program. After doing a return on investment analysis, and they were able to see that they were saving more money than they thought they were on the program, and they ultimately did this really interesting thing because Sutter has both a Medicare fee-for-service and a Medicare Advantage population. And they found that they were saving so much on the Medicare Advantage side with those AIM participants that they could offer the AIM program to their fee-for-service beneficiaries as well and still have savings and increase the quality of life for those beneficiaries. But then it also became, as we said, kind of one of those unintended benefits, a marketing opportunity for them to further their enrollment. Had they not been able to do that kind of deep analysis, then the program wouldn't have been able to expand and grow.
That's a great
Was that-
example. Yeah,
Okay. Great.
That's exactly what I was thinking of. I guess my follow-up question is, have you ever done any kind of analysis regarding the benefits of having a patient family advisory council?
So in the work that we have done at the foundation, we haven't had that type of analysis. With the ROI tool, you could include information. You could include the costs of a patient family advisory group as your costs, and then you would just have to be able to make informed estimates about how it is potentially reducing or avoiding utilization. And I forgot that one caveat to the tool. The results are only as good as the data that you have to put into the tool. So if you don't have good data or you make inaccurate assumptions, the calculations aren't going to be as strong.
Understood.
But
Thank
I think
you.
that's and I think it's something that's interesting to think about too with the work that all of you do is when you have a patient and family advisory council, is it for the whole system? Is it for one aspect of the system? Is it for a specific model? Because when we think about the return on investment, and especially when we think about person-centered care, we're not, we're targeting a subset of the population, that 5 or 10%. So I think that as you're trying to make the case or the business case to quantify the impact of the work that you do, I think you're going to have to be able to really draw a line from how the council impacts the delivery of care for that specific subset of the population. Does that make
Right.
sense?
Yeah. That does make sense. Thank you, Erin. Were
Yeah.
there any other questions for Erin? Because I actually had a question, and I guess it kind of piggybacks on that conversation about the advisory councils, kind of. And I think you alluded to it a little bit, but my question was, could any type of healthcare organization utilize this tool? I think you had said that they were developing a new tool or working on this tool to focus on the more broader population. Can you talk a little bit more about that?
Sure. So this can absolutely be used by any healthcare delivery system.
Mm-hmm.
It can also be used by, I'm sorry, my visual of our slides just went away on my computer. It just distracted me, but it's okay. I don't need it. So this can be used by any healthcare delivery system. We also find that community-based organizations who are working with the healthcare sector are finding this useful to be able to quantify the impact of their intervention on utilization. And again, when we structured this and designed this, we were thinking about it from an older adult perspective. Mm-hmm. And the next version that will hopefully be coming out in the next year is looking at the broader population and really focusing specifically on how do you also account for social determinants of health.
Mm-hmm.
Does that answer your question, Lindsay?
Yes, thank you.
Okay.
Were there any other questions from the group? If not, I have one more question for you, Erin, since we have the time. And I'm on the slide that I had the question about. How were these 6 ROI drivers, how were they developed?
So I would say that it's less about them being developed and more about them being identified.
Uh-huh.
And if you read our big long theoretical paper around the business case, they're detailed out there. But essentially, each of these were identified based on research about what's happening in the field.
Mm-hmm.
So not only things that have been published, because for most of the healthcare sector, they don't publish the innovations they're doing because it's proprietary information. Mm-hmm. But for stuff that was published, but also interviews with different delivery systems that are providing care in what we would call a person-centered way and who are seeing results. And based on all of that research, that's where it was identified that these are the 6 things that are really drivers for why person-centered care should be implemented, because they do result in a favorable return on investment.
Mm-hmm. Great, that makes sense. Thank you.
And one of the things I'll say about the tool as well is it also helps people see that maybe where they can make changes that they're not having a good return on investment. Outside of this specific work, we did some work with a health plan that had a model in place, and they just weren't getting the results that they were looking for. And what they identified was they had all the components, but the theory and the process of the model wasn't working for their team and the infrastructure they had. And so they scratched that model, and then they brought in Grace Team Care, which is the Grace model. And in changing the process and the delivery of care, changing how the team worked together was able to bring them then not only the improved outcomes for the individuals, but they were then able to see the cost savings. So sometimes when you're looking at a model and you're trying to make the case as to why we should continue it, and you know the business case being a critical component, sometimes you might just need to tweak something a little bit, whether it's the process, whether it's your target population. Maybe you've gone too broad or you've gone too narrow. Maybe it's the intensity of the intervention. And as you make all of those little tweaks, you can reflect them in the ROI tool to get that estimate of what your return would be.
Nice. Very cool. Okay, were there any other questions from the audience? If not, I'll stop on the SCAN Foundation information. And as Erin said, I think her information is on that website, so you can give her a call if you have any other questions going forward. And I would like to thank Erin so much. This was very informative, very interesting, and I appreciate you joining us on this month's workshop. And thank you to all of the participants as well. And with that, I'll say happy Memorial Day. Have a great 3-day weekend. Thank you so much, Erin.
Thanks, Lindsay and Erin.
Thank you.
Thank you all.
Bye-bye.
Thanks.
Thank you.
Bye, everyone.